which is necessary for bowel elimination. Carbohydrates can be divided into two basic types, complex and simple. Complex carbohydrates are found in bread, cereal, potatoes, rice, pasta, vegetables, and fruits. Simple carbohydrates are found in sugars, sweets, syrups, and jellies. Simple carbohydrates do not have the same nutritional value that complex carbohydrates have. Figure 8-1, caption, some sources of complex carbohydrates. 3. Protein. Proteins are part of every body cell. They are needed for tissue growth and repair. Proteins also supply energy for the body. Excess proteins are excreted by the kidneys or stored as body fat. Sources of protein include seafood, poultry, meat, eggs, milk, cheese, nuts, nut butters, peas, beans or legumes, and vegetarian meat substitutes from a variety of food sources. Whole grain cereals, pastas, rice, and breads contain some proteins too. Figure 8-2, caption, some sources of protein. 4. Fats. Fat helps the body store energy. Fats add flavor to food and are important for the absorption of certain vitamins. Excess fat in the diet is stored as fat in the body. Fat falls into 4 categories: saturated, trans, monounsaturated, and polyunsaturated. Saturated and trans fats can increase cholesterol levels and the risk of some diseases, such as cardiovascular disease. Monounsaturated and polyunsaturated fats can be helpful in the diet and can decrease the risk of cardiovascular disease and type 2 diabetes. Some fats come from animal sources, such as butter, beef, pork, fowl, fish, and dairy products. Some fats come from plant sources, such as olives, nuts, and seeds. 5. Vitamins. Vitamins are substances needed by the body to function. The body cannot make most vitamins. They can only be obtained from certain foods. Vitamins A, D, E, and K are fat-soluble vitamins. This means they are carried and stored in body fat. Vitamins B and C are water-soluble vitamins. They are broken down by water in the body and cannot be stored. Excess vitamins B and C are eliminated in urine and feces. Figure 8-3, caption, some animal sources of fat are in the top photo and plant sources are in the bottom photo. 6. Minerals. Minerals maintain body functions. Minerals help build bones, make hormones, and help in blood formation. They provide energy and control body processes. Zinc, iron, calcium, and magnesium are examples of minerals. Minerals are found in many foods. Most foods have several nutrients. However, no one food has all the nutrients needed for a healthy body. This is why it is important to eat a daily diet that is well balanced. There is not one single dietary plan that is right for everyone. People have different nutritional needs depending upon their age, gender, and activity level. In 2011, in response to increasing rates of obesity, the United States Department of Agriculture, USDA, USDA.gov, developed MyPlate to help people build a healthy plate at mealtimes. The MyPlate icon emphasizes vegetables, fruits, grains, protein, and low-fat dairy products. MyPlate gives suggestions and tools for making healthy choices. It does not provide specific messages about what a person should eat. The MyPlate icon includes the following food groups. Figure 8-4, caption, the U.S. Department of Agriculture developed the MyPlate icon and website, choosemyplate.gov, to help promote healthy eating practices. Vegetables and fruits. Vegetables and fruits should make up half of a person's plate. Vegetables include all fresh, frozen, canned, and dried vegetables and vegetable juices. There are 5 subgroups within the vegetable group, organized by their nutritional content. These are dark green vegetables, red and orange vegetables, beans and peas, starchy vegetables, and other vegetables. A variety of vegetables from these subgroups should be eaten every day. Dark green, red, and orange vegetables have the best nutritional content. Figure 8-5, caption, eating a variety of vegetables every day, especially dark green, red, and orange vegetables, helps promote health. Vegetables are low in fat and calories and have no cholesterol, although sauces and seasonings may add fat, calories, and cholesterol. They are good sources of dietary fiber, potassium, vitamin A, vitamin E, and vitamin C. Fruits include all fresh, frozen, canned, and dried fruits and 100% fruit juices. Most choices should be whole, cut up, or pureed fruit, rather than juice, for the additional dietary fiber provided. Fruit can be added as a main dish, side dish, or dessert. Fruits, like vegetables, are naturally low in fat, sodium, and calories, and have no cholesterol. They are important sources of dietary fiber and many nutrients, including folic acid, potassium, and vitamin C. Foods containing dietary fiber help provide a feeling of fullness with fewer calories. Folic acid helps the body form red blood cells. Vitamin C is important for growth and repair of body tissues. Grains. A person should make half his grain intake whole grains. There are many different grains. Some common ones are wheat, rice, oats, cornmeal, and barley. Foods made from grains include bread, pasta, oatmeal, breakfast cereals, tortillas, and grits. Grains can be divided into two groups, whole grains and refined grains. Whole grains contain bran and germ, as well as the endosperm. Refined grains retain only the endosperm. The endosperm is the tissue within flowering plants. It surrounds and nourishes the plant embryo. Examples of whole grains include brown rice, wild rice, bulgur, oatmeal, whole grain corn, whole oats, whole wheat, and whole rye. Foods rich in fiber reduce the risk of heart disease and other diseases and may reduce constipation. Protein. MyPlate guidelines emphasize the importance of eating a variety of protein foods every week. Meat, poultry, seafood, and eggs are animal sources of proteins. Beans, peas, soy products, vegetarian meat substitutes, nuts, and seeds are plant sources of proteins. Seafood should be eaten twice a week in place of meat or poultry. Seafood that is higher in oils and low in mercury, such as salmon or trout, is a better choice. Lean meats and poultry, as well as eggs and egg whites, can be eaten on a regular basis. A person should eat plant-based protein foods more often. Beans and peas, soy products, tofu, tempeh, many vegetarian products, vegetarian meat substitutes, nuts, and seeds are low in saturated fat and high in fiber. Some nuts and seeds, flax, walnuts, are excellent sources of essential fatty acids. These acids may reduce the risk of heart disease. Sunflower seeds and almonds are good sources of vitamin E. Figure 8-6, caption. Fish, like this salmon, contains healthy oils and is a good source of protein. Dairy. All milk products and foods made from milk that retain their calcium content, such as yogurt and cheese, are part of the dairy category. Most dairy group choices should be fat-free, 0%, or low-fat, 1%. Fat-free or low-fat milk or yogurt should be chosen more often than cheese. Milk and yogurt contain less sodium than most cheeses. Milk provides nutrients that are vital for the health and maintenance of the body. These nutrients include calcium, potassium, vitamin D, and protein. Fat-free or low-fat milk provides these nutrients without the extra calories and saturated fat. Soy products enriched with calcium are an alternative to dairy foods. The following guidelines provide additional tips for making healthy food choices. Guidelines. Healthy food choices. Balance calories. Calorie balance is the relationship between the calories obtained from food and fluids consumed and the calories used during normal body functions and physical activity. Proper calorie intake varies from person to person. To find the proper calorie intake, the USDA suggests visiting choosemyplate.gov. Enjoy your food, but eat less. Eating too fast or eating without paying attention to your food can lead to overeating. Know when you feel hungry and when you are full. Notice what you are eating. Stop eating when you feel satisfied. Avoid oversized portions. Choose smaller-sized portions when eating. Portion out food before you eat it. Use smaller bowls and plates for meals. When eating out, split food with others or take part of your meal home. Eat these foods more often: vegetables, fruits, whole grains, and fat-free or 1% milk and low-fat dairy products. These foods have better nutrients for health. Eat these foods less often: foods high in solid fats, added sugars, and salt. These foods include fatty meats like bacon and hot dogs, cheese, fried foods, ice cream, and cookies. Check sodium content in foods. Read product labels to determine if they contain salt or sodium. Foods high in sodium include the following: cured meats, including ham, bacon, lunch meat, sausage, and hot dogs. Salty or smoked fish, including herring, sardines, anchovies, and smoked salmon. Processed cheese and some other cheeses. Salted foods, including nuts, pretzels, potato chips, and dips. Vegetables preserved in brine, such as pickles, sauerkraut, and olives. Sauces with high concentrations of salt, including steak and soy sauces, ketchup, mustard, and mayonnaise. Commercially prepared foods such as breads, canned soups and vegetables, and certain breakfast cereals. Select canned foods that are labeled sodium-free, very low sodium, or reduced sodium. Drink water instead of sugary drinks. Drinking water or unsweetened beverages reduces sugar and calorie intake. Sweetened beverages, such as soda, fruit punch, and sports drinks, are a major source of sugar and calories in diets. Learning Objective 2. Describe factors that influence food preferences. Culture, ethnicity, income, education, religion, and geography all affect ideas about nutrition. Food preferences may be formed by what a person ate as a child, by what tastes good, or by personal beliefs about what should be eaten. Some people choose not to eat any animals or animal products such as steak, chicken, butter, or eggs. These people are called vegetarians or vegans, depending on what they eat. Figure 8-7, caption, food likes and dislikes are influenced by what a person ate as a child. The region or culture a person grows up in often affects his food preferences. People from the southwestern United States may like spicy foods. Southern cooking may include fried foods, such as fried chicken or fried okra. Ethnic groups often share common foods. These may be eaten at certain times of the year, or all the time. Religious beliefs affect diet too. Some Muslims and Jewish people do not eat any pork. Mormons may not drink alcohol, coffee, or tea. Food preferences may change while a resident is living at a facility. Just as anyone may decide that he likes some foods for a time and then change his mind, so may a resident. Providing person-centered care means respecting each resident's preferences. It is never appropriate to make fun of personal preferences. If an NA notices that certain food is not being eaten, no matter how small the amount, she should report it to the nurse. Residents' Rights Box 8-1, Food Choices. Residents have the legal right to make choices about their food. They can choose what kind of food they want to eat. They can refuse the food and drink being offered. NAs must honor a resident's personal beliefs and preferences about selecting and avoiding specific foods. Although residents have the right to refuse, it is best to ask questions when they do. For example, if a resident refuses dinner, the NA can ask if there is something wrong with the food. The resident may say he is Jewish and cannot eat a pork chop because it is not kosher. NA should respond to requests for different food in a pleasant way. The NA can explain that she will report to the nurse and will get him another meal as quickly as possible. She can take the tray to the dietitian or dietary department so that an alternative may be offered. Learning Objective 3. Explain special diets. Residents who do not have any health problems that require a change in diet often eat a regular diet. However, residents who are ill may be placed on therapeutic, modified, or special diets. With special diets, certain nutrients or fluids may need to be restricted or removed. Some medications may also interact with certain foods, which then must be eliminated. Residents who do not eat enough may be placed on supplementary diets. Diets are also used for weight control and food allergies. Several types of diets are available for different illnesses. Some residents may be on a combination of special diets. The care plan should specify any special diet the resident needs. NAs must never modify a resident's diet. Special diets can only be prescribed by doctors and planned by dietitians, along with residents. Low-sodium diet. People are most familiar with sodium as one of the two components of salt. Salt is restricted first in a low-sodium diet because it is high in sodium. Residents who have high blood pressure, heart disease, or kidney disease may be placed on a low-sodium diet. A modified fluid intake may also be required for people with these conditions. For residents on a low-sodium diet, salt will not be used. Salt shakers or packets will not be on the diet tray. Common abbreviations for this diet are low NA, which means low sodium, or NAS, which stands for no added salt. Fluid-restricted diet. The fluid taken into the body through food and fluids must equal the fluid that leaves the body through perspiration, stool, urine, and expiration. This is fluid balance. When fluid intake is greater than fluid output, body tissues become swollen with fluid. People with severe heart disease or kidney disease may have trouble processing fluid. To prevent further damage, doctors may restrict fluid intake. For residents on fluid restriction, the NA will measure and document exact amounts of fluid intake and report excesses to the nurse. Additional fluids or foods that count as fluids such as ice cream, puddings, gelatin, etc. should not be offered. If the resident complains of thirst or requests fluids, the NA should tell the nurse. A common abbreviation for this diet is RF, which stands for Restrict Fluids. Low-protein diet. People who have kidney disease may be on low-protein diets. Protein is restricted because it breaks down into compounds that may lead to further kidney damage. The extent of the restrictions depends on the stage of the disease and if the resident is on dialysis. Vegetables and starches, such as breads and pasta, are encouraged. Low-fat diet. Eating a diet high in saturated fats may put a person at risk for heart disease. Choosing to eat unsaturated fat can reduce the risk of heart disease and improve HDL, good cholesterol levels. People who have heart disease or who have had heart attacks are often prescribed a diet that is low in saturated fat. People with gallbladder disease, diseases that interfere with fat digestion, and liver disease are also placed on a low-fat diet. This diet limits the intake of saturated fat. Trans fat should be avoided. Foods high in saturated fat include fatty meats. high-fat dairy products, especially cheese, hydrogenated oils, and desserts and baked goods. Foods that contain healthier fats include olive oil, nuts, avocado, and fatty fish like salmon. People who have gallbladder disease or other digestive problems may be placed on a diet that restricts all fats. Low fat may be listed on the diet card for this diet. Sometimes cardiac diet may be listed on the diet card, which means a diet that is low in sodium, fat, and cholesterol, as well as in excess sugar. Figure 8-8, caption: healthier fats come from olives, nuts, avocados, and fatty fish. Modified calorie diet. Some residents may need to reduce calories to lose weight or prevent weight gain. Other residents may need to gain weight or increase calories because of malnutrition, surgery, illness, or fever. Common abbreviations for this diet are low-cal or high-cal. Diabetic diet. Calories and carbohydrates are carefully controlled in the diets of residents who have diabetes. Protein and fats are also regulated. The types and amounts of food are determined by nutritional and energy needs. A dietitian and the resident will make up a meal plan. It will include all the right types and amounts of food for each day. The meal plan may use a carbohydrate counting approach, often called carb counting. After the proper amount of carbohydrates is determined by the dietitian, they need to be counted in each meal or snack. Nutrition labels need to be read, paying attention to serving size and carbohydrate content. Food portions may need to be measured. To keep their blood glucose levels near normal, residents who have diabetes must eat the right amount of the right type of food at the right time. They must eat all that is served. NAs should encourage them to do so. Other foods should not be offered without the nurse's approval. If a resident will not eat what is recommended, does not finish meals, or is not following the diet, the NA should tell the nurse. People who have diabetes should avoid foods that are high in sugar. Sugary foods can cause problems with insulin balance. A meal tray for a resident with diabetes may have artificial sweetener, low-calorie jelly, and/or low-calorie maple syrup. Artificial sweeteners, rather than sugar, may be used in coffee or tea. The American Diabetes Association's ADA website, diabetes.org, has more information. Vegetarian diet. Health issues, such as diabetes or obesity, may cause a person to require a vegetarian diet. A person may also choose to eat a vegetarian diet for religious reasons, or due to a dislike of meat, a compassion for animals, a belief in nonviolence, or financial issues. There are different types of vegetarian diets. A lacto-ovo-vegetarian diet excludes all meats, fish, and poultry, but allows eggs and dairy products. A lacto-vegetarian diet eliminates poultry, meats, fish, and eggs, but allows dairy products. An ovo-vegetarian diet omits all meats, fish, poultry, and dairy products, but allows eggs. A vegan diet eliminates poultry, meats, fish, eggs, and dairy products, along with all foods that are derived from animals. A person might choose to limit his intake of animal-based foods by being a pescatarian. A pescatarian diet eliminates all meats and poultry, but allows fish and other seafood. Eggs and dairy products may be consumed. Liquid diet. A liquid diet is usually ordered for a short time due to a medical condition or before or after a test or surgery. It is ordered when a resident needs to keep the intestinal tract free of food. A liquid diet consists of foods that are in a liquid state at body temperature. Liquid diets are usually ordered as clear or full. A clear liquid diet includes clear juices, broth, gelatin, and popsicles. A full liquid diet includes all the liquids served on a clear liquid diet with the addition of cream soups, milk, and ice cream. Soft diet and mechanical soft diet. The soft diet is soft in texture and consists of soft or chopped foods that are easier to chew and swallow. Foods that are hard to chew and swallow, such as raw fruits and vegetables and some meats, will be restricted. High-fiber foods, fried foods, and spicy foods may also be limited. Doctors order this diet for residents who have trouble chewing and swallowing due to dental problems or other medical conditions. It is also ordered for people who are going from a liquid diet to a regular diet. The mechanical soft diet consists of chopped or blended foods that are easier to chew and swallow. Foods are prepared with blenders, food processors, or cutting utensils. Unlike the soft diet, the mechanical soft diet does not limit spices, fat, or fiber. Only the texture of the foods is changed. This diet is used for people recovering from surgery or who have trouble chewing and swallowing. Pureed diet. To puree a food means to blend or grind it into a thick paste of baby food consistency. The food should be thick enough to hold its form in the mouth. This diet does not require a person to chew his food. A pureed diet is often used for people who have trouble chewing and/or swallowing more textured foods. Orange Box 8-1, Nutritional Supplements. Illness and injury may call for nutritional supplements to be added to the resident's diet. Certain medications also change the need for nutrients. For example, some medication prescribed for high blood pressure increases the need for potassium. Nutritional supplements may come in a powdered or liquid form. Some supplements may be pre-mixed and ready to drink. Powdered supplements need to be mixed with a liquid before being taken. NAs may not be allowed to prepare supplements and/or hand them to residents. They should follow facility policy. The NA may need to make sure the resident takes the supplement at the ordered time. A resident who is ill, tired, or in pain may not have much of an appetite. It may take a long time for him to drink a large glass of thick liquid. The NA should be patient and encouraging. If a resident does not want to drink the supplement, the NA should not insist that he do so. However, she should report this to the nurse. Learning Objective 4. Describe how to assist residents in maintaining fluid balance. Water is an essential nutrient for life. Proper fluid intake is important. Drinking enough water or other fluids per day can help prevent constipation and urinary incontinence. Without enough fluid, urine becomes concentrated. More concentrated urine creates a higher risk for infection. Proper fluid intake also helps to dilute wastes and flush out the urinary system. It may even help prevent confusion. The sense of thirst can lessen as people age. Infection, fever, diarrhea, and some medications will also increase the need for fluid intake. NA should remind residents to drink fluids often. Some residents will drink more fluids if they are offered them in smaller amounts rather than in one large glassful. Some residents will have an order to encourage or restrict fluids because of medical conditions. When a resident has a restrict fluids (RF) order, the NA should not give the resident any extra fluids or a water pitcher unless the nurse approves it. Figure 8-9, caption. Drinking enough water and other fluids promotes health. NA should encourage residents to drink fluids often. The abbreviation NPO means nothing by mouth. This means that a resident is not allowed to have anything to eat or drink. Some residents have such a severe problem with swallowing that it is unsafe to give them anything by mouth. These residents will receive nutrition through a feeding tube or intravenously. Some residents may not be able to eat and drink for a short time before a medical test or surgery. NAs need to know this abbreviation. They should never offer any food or drink, even water, to a resident with this order. Dehydration occurs when a person does not have enough fluid in the body. Dehydration is a serious condition. It is a major problem among the elderly. People can become dehydrated if they do not drink enough or if they have diarrhea or are vomiting. Preventing dehydration is very important. Guidelines: preventing dehydration. Report observations and warning signs to the nurse immediately. Encourage residents to drink every time you see them. Offer fresh water or other fluids often. Offer drinks that the resident enjoys. Some residents may prefer water or sparkling water, seltzer water. Some may not like water and prefer other types of beverages, such as juice, soda, tea, or milk. Some residents do not want ice in their drinks. As always, it is important to provide person-centered care. Honor personal preferences. Report to the nurse if the resident tells you she does not like the fluids being served. Ice chips, frozen flavored ice sticks, and gelatin are also forms of liquids. Offer them often. Do not offer ice chips or sticks if a resident has a swallowing problem. If appropriate, offer sips of liquid between bites of food at meals and snacks. Make sure the pitcher and cup are nearby and are light enough for the resident to lift. Offer assistance if the resident cannot drink without help. Use adaptive cups as needed. Record fluid intake and output. Observing and reporting. Dehydration. Report any of these to the nurse. Resident drinks fewer than 6 8-ounce glasses of liquid per day. Resident drinks little or no fluids at meals. Resident needs help drinking from a cup or glass. Resident has trouble swallowing liquids. Resident has frequent vomiting, diarrhea, or fever. Resident is easily confused or tired. Report any of these signs and symptoms. Dry mouth, cracked lips, sunken eyes, dark urine, strong smelling urine, weight loss, complaints of abdominal pain. Procedure: serving fresh water. Equipment needed: water pitcher, ice scoop, cup, straw, gloves. 1. Identify yourself by name. Identify the resident by name. Resident has right to know identity of his or her caregiver. Addressing resident by name shows respect and establishes correct identification. 2. Wash your hands. Provides for infection prevention. 3. Put on gloves. Promotes infection prevention. 4. Scoop ice into the water pitcher without touching the ice scoop to the pitcher. Add fresh water. Do not touch the pitcher to the spout or faucet. 5. Use and store the ice scoop properly. Do not allow ice to touch your gloved hand and fall back into the container. Place the scoop in the proper receptacle after each use. Avoid contamination of ice. 6. Take the pitcher to the resident. 7. Pour water into the resident's cup. Offer the resident a drink of water. Leave the pitcher and cup at the bedside. Encourages resident to maintain hydration. 8. Make sure that the pitcher and cup are light enough for the resident to lift. Leave a straw if the resident desires and does not have swallowing problems. Demonstrates understanding of resident's abilities and/or limitations. Prevents dehydration. 9. Place call light within resident's reach. Allows resident to communicate with staff as necessary. 10. Remove and discard gloves. 11. Wash your hands. Provides for infection prevention. Fluid overload occurs when the body cannot handle the fluid consumed. This often affects people with heart or kidney disease. Observing and reporting. Fluid overload. Report any of these to the nurse. Swelling, edema of extremities, ankles, feet, fingers, hands. Edema is swelling caused by excess fluid in body tissues. Weight gain. Daily weight gain of 1 to 2 pounds. Decreased urine output. Shortness of breath. Increased heart rate. Anxiety. Skin that appears tight, smooth, or shiny. Learning Objective 5. List ways to identify and prevent unintended weight loss. Unintended weight loss is a serious problem for the elderly. Weight loss can mean that the resident has a serious medical condition. It can lead to skin breakdown. This leads to pressure injuries. It is very important for NAs to report any weight loss, no matter how small. If a resident has diabetes, COPD, cancer, HIV, or other diseases, he is at a greater risk for malnutrition. Chapter 4 has more information. Guidelines. Preventing unintended weight loss. Report observations and warning signs to the nurse. Food should look, taste, and smell good. The resident may have a poor sense of taste and smell. Encourage residents to eat. Talk about food being served in a positive tone of voice. Use positive words. Figure 8-10, caption. Be friendly and positive while helping residents with eating. This helps promote appetite and may prevent weight loss. Honor residents' food likes and dislikes. Offer different kinds of foods and beverages. Help residents who have trouble feeding themselves. Season foods to residents' preferences. Allow time for residents to finish eating. Tell the nurse if residents have trouble using utensils. Record meal/snack intake. Give oral care before and after meals if the resident requests it. Position resident sitting upright for eating. If resident has had a loss of appetite and/or seems sad, ask about it. Observing and reporting unintended weight loss. Report any of these to the nurse. Resident needs help eating or drinking. Resident eats less than 75% of meals served. Resident has mouth pain. Resident has dentures that do not fit. Resident has difficulty chewing or swallowing. Resident coughs or chokes while eating. Resident is sad, has crying spells, or withdraws from others. Resident is confused, wanders, or paces. Learning Objective 6. Identify ways to promote appetites at mealtime. Mealtime is often one of the most anticipated times of a resident's day. Mealtime is important for getting proper nourishment. It is also a time for socializing, which has a positive effect on eating. Socializing can help prevent weight loss, dehydration, and malnutrition. It can also prevent loneliness and boredom. Promoting healthy eating is an important part of a nursing assistant's job. Mealtime should be pleasant and enjoyable. Guidelines. Promoting appetites. Assist residents with grooming and hygiene tasks before dining as needed. Give oral care before eating if requested. Offer a trip to the bathroom or help with elimination needs before eating. Help residents wash hands before eating. Encourage the use of dentures, eyeglasses, and hearing aids. If these are damaged, notify the nurse. Check the environment. The temperature should be comfortable. Address any odors. Keep the noise level low. Televisions should be off. Do not shout or raise your voice. Do not bang plates or cups. Seat residents next to their friends or people with like interests. Encourage conversation. Properly position residents for eating. Usually, the proper position is upright at a 90-degree angle. This helps prevent swallowing problems. If residents use a wheelchair, make sure they are sitting at a table that is the right height. Most facilities have adjustable tables for wheelchairs. Residents who use jerry chairs, reclining chairs on wheels, should be upright, not reclined while eating. Serve food promptly to maintain the correct temperature. Keep food covered until ready to serve. Plates and trays should look appetizing. If they do not, inform your supervisor. Give the resident the proper eating tools. Use assistive utensils if needed. Figure 8-11, caption. Special cups, plates with guards on them, and utensils with thick handles that are easier to hold are examples of assistive devices that can help with eating. Photos courtesy of North Coast Medical Incorporated, 800-821-9319, www.ncmedical.com. Be cheerful, positive, and helpful. Make conversation if the resident wishes to talk. Honor requests regarding food. Residents have the legal right to ask for and receive different food. They can also ask for additional food. Learning Objective 7. Demonstrate how to assist with eating. Residents will need different levels of help with eating. Some residents will not need any help. Other residents will only need help setting up. They may only need someone to open cartons and cut and season their food. Once that is done, they can feed themselves. The NA should check with these residents from time to time to see if they need anything else. Other residents will be completely unable to feed themselves. It will be the NA's job to feed them. Residents who must be fed are often embarrassed and depressed about their dependence on another person. NA should be sensitive to this and give privacy while residents are eating. Residents should not be rushed through their meals. NA should only give assistance as specified, when necessary, or when residents request it. They should encourage residents to do what they can. For example, if a resident can hold and use a napkin, she should. If she can hold and eat finger foods, the NA should offer them. There are devices that help residents eat more independently. More adaptive devices are shown in Chapter 9. Guidelines: assisting a resident with eating. Before you begin serving or helping residents, wash your hands. It is very important to identify residents before serving a meal tray. Feeding a resident the wrong food can cause serious problems, even death. Verify that you have the right resident. Check the diet card against the name listed outside the door, if available. Ask the resident to state his name. Check that the diet on the tray is correct and matches the diet card. Sit at a resident's eye level. The resident should be sitting upright at a 90-degree angle. Make eye contact with the resident. If the resident wishes, allow time for prayer. Never treat the resident like a child. This is embarrassing and disrespectful. It is hard for many people to accept help with eating. Be supportive and encouraging. Test the temperature of the food by putting your hand over the dish to sense the heat. Do not touch food to test its temperature. If you think the food is too hot, do not blow on it to cool it. Offer other food to give it time to cool. Cut foods and pour liquids as needed. Season foods to the resident's preference. Identify the foods and fluids that are in front of the resident. Call pureed foods by the correct name. For example, ask, "Would you like green beans?" rather than referring to it as some green stuff. Ask the resident which food he wants to eat first. Allow him to make the choice, even if he wants to eat dessert first. Do not mix foods unless the resident requests it. Do not rush the meal. Allow time for the resident to chew and swallow each bite. Be relaxed. Be social and friendly. Make simple conversation if the resident wishes to do so. Use appropriate topics such as the news, weather, the resident's life, things the resident enjoys, and food preferences. Say positive things about the food being served, such as, "This smells really good," and "This looks really fresh." Give the resident your full attention while she is eating. Do not talk to other staff members while helping a resident eat. Alternate food and drink. Alternating cold and hot foods, or bland foods and sweets, can help increase appetite. If the resident wants a different food from what is being served, inform the dietitian so that an alternative may be offered. Resident Rights Box 8-2, Clothing Protectors. Residents have the right to refuse to wear a clothing protector. An NA can offer a clothing protector but should not insist that a resident wear one. The resident's wishes should be respected. A clothing protector should not be referred to as a bib. Residents are not children, and this is disrespectful. Procedure: feeding a resident. Equipment needed: meal and beverage, eating utensils, clothing protector, washcloths, wipes, or towel. 1. Identify yourself by name. Identify the resident by name. Resident has right to know identity of his or her caregiver. Addressing resident by name shows respect and establishes correct identification. 2. Wash your hands. Provides for infection prevention. 3. Explain procedure to resident. Speak clearly, slowly, and directly. Maintain face-to-face contact whenever possible. Promote understanding and independence. 4. Provide for resident privacy with curtain, screen, or door. Maintains residents' right to privacy and dignity. 5. Look at the diet card or menu. Ask the resident to state her name. If the resident is unable to state her name, check identification another way, such as looking at a photo ID or an armband. Verify that the resident has received the right tray. Tray should only contain foods, fluids, and condiments permitted on the diet. 6. Raise the head of the bed. Make sure the resident is in an upright sitting position at a 90-degree angle. Promotes ease of swallowing. Prevents aspiration of food and beverage. 7. Adjust bed height to where you will be able to sit at the resident's eye level. Lock bed wheels. 8. Place the tray where it can be easily seen by the resident, such as on the overbed table. 9. Help the resident to clean her hands if she cannot do it herself. Promotes good hygiene and infection prevention. 10. Help the resident put on clothing protector if desired. Protects residents' clothing from food and beverage spills. 11. Sit in a chair facing the resident at the resident's eye level. Sit on the stronger side if the resident has one-sided weakness. Promotes good communication. Lets resident know that he or she will not be rushed while eating. Figure 8-12, caption. The resident should be sitting upright and the NA should be sitting at her eye level. 12. Tell the resident what foods and beverage are on the tray. Offer a drink of beverage. Ask what the resident would like to eat first. Resident has legal right to make decisions. 13. Check the temperature of the food. Using utensils, offer the food in bite-sized pieces. Tell the resident the content of each bite of food offered. Alternate types of food, allowing for the resident's preferences. Do not feed all of one type before offering another type. Make sure the resident's mouth is empty before the next bite or sip. Report any swallowing problems to the nurse immediately. Small pieces are easier to chew and lessen the risk of choking. If the mouth is empty before offering more food, it lessens the risk of choking. Figure 8-13, caption. Offer the food in bite-sized pieces. Tell the resident the content of each bite of food. 14. Offer sips of beverage throughout the meal. If you are holding the cup, touch it to the resident's lips before you tip it. Give small, frequent sips. Promotes ease of swallowing. 15. Talk with the resident during the meal. Do not rush the resident. Makes mealtime more enjoyable. Figure 8-14, caption. Socializing during mealtime makes eating more enjoyable. It may help promote a healthy appetite. 16. Wipe food from the resident's mouth and hands as needed during the meal. Wipe again at the end of the meal. Maintains resident's dignity. Figure 8-15, caption. Wiping food from the mouth during the meal helps to maintain the resident's dignity. 17. Remove the clothing protector if used. Place it and used washcloths or wipes in the proper containers. 18. Remove the food tray. Check for eyeglasses, dentures, or any personal items before removing the tray. Place tray in the proper area. 19. Make resident comfortable. Keep the resident in the upright position for at least 30 minutes. Make sure the bed is free of crumbs. Food left on sheets can cause skin breakdown. 20. Return bed to lowest position. Remove privacy measures. Provide for safety. 21. Place call light within resident's reach. Allows resident to communicate with staff as necessary. 22. Wash your hands. Provides for infection prevention. 23. Report any changes in resident to the nurse. Provides nurse with information to assess resident. 24. Document procedure using facility guidelines. If you do not document the care, legally it did not happen. Food trays and plates should also be observed after the meal. This helps to identify residents with poor appetites. It may also signal illness, a problem such as dentures that do not fit properly, or a change in food preferences. All facilities keep track of how much food and fluid a resident consumes. Percentages are often used to document food intake, but the method can vary. The dietitian calculates the percentages for meals. The NA may be asked to document how much of the entire meal a resident ate. For example, if the resident ate the entire meal served, the NA would document that 100% was eaten. If the resident ate about half of the meal, the NA would document 50% eaten, and so on. NAs must document food intake accurately. They should follow their facility's policies. Learning Objective 8. Identify signs and symptoms of swallowing problems. Residents may have conditions that make eating or swallowing difficult. Dysphagia means difficulty in swallowing. A stroke, or CVA, can cause weakness and paralysis on one side of the body. Nerve and muscle damage from head and neck cancer, multiple sclerosis, Parkinson's disease, or Alzheimer's disease may also be present. If a resident has trouble swallowing, soft foods and thickened liquids will be served. A special cup will help make swallowing easier. NAs need to be able to recognize and report signs that a resident has a swallowing problem. Signs and symptoms of swallowing problems include the following: coughing during or after meals, choking during meals, dribbling saliva, food, or fluid from the mouth, having food residue inside the mouth or cheeks during or after meals, gurgling during or after meals or losing one's voice, eating slowly, avoiding eating, spitting out pieces of food, swallowing several times per mouthful, clearing the throat frequently during and after meals, watering eyes when eating or drinking, food or fluid coming up into the nose, making a visible effort to swallow, breathing rapidly or with shorter breaths while eating or drinking, difficulty chewing food, difficulty swallowing medications. Residents with swallowing problems may be restricted to consuming only thickened liquids. Thickened liquids have a thickening powder or agent added to them. This improves the ability to control fluid in the mouth and throat. A doctor orders the necessary thickness after the resident has been evaluated by a speech-language pathologist. Some beverages arrive already thickened and ready to drink. Other beverages must have the thickening agent added before serving. If thickening is ordered, it must be used with all liquids. This means that regular liquids, such as water or other beverages, should not be offered to residents who must have thickened liquids. There are 3 basic thickened consistencies. 1. Nectar thick. This consistency is thicker than water. It is the thickness of a thick juice, such as a pear nectar or tomato juice. A resident can drink this from a cup. 2. Honey thick. This consistency has the thickness of honey. It will pour very slowly. A resident will usually use a spoon to consume it. 3. Pudding thick. With this consistency, the liquids have become semi-solid, much like pudding. A spoon should stand up straight in the glass when put into the middle of the drink. A resident must consume these liquids with a spoon. Swallowing problems put residents at risk for choking on food or drink. Inhaling food, fluid, or foreign material into the lungs is called aspiration. Aspiration can cause pneumonia or death. An NA should alert the nurse immediately if any problems occur while eating. Guidelines: preventing aspiration. Position residents in an upright position, 90-degree angle, for eating and drinking. Do not feed residents in a reclined position. Offer small pieces of food or small spoonfuls of pureed food. Feed residents slowly. Do not rush them. Place food in the unaffected or stronger side of the mouth. Make sure the mouth is empty before offering another bite of food or sip of drink. Keep residents in the upright position for at least 30 minutes after eating and drinking. When the digestive system does not function properly, parenteral nutrition, PN, sometimes referred to as total parenteral nutrition, may be needed. With parenteral nutrition, a solution of nutrients goes directly into the bloodstream. It bypasses the digestive system. NAs are not responsible for parenteral nutrition. They may be assigned to measure the resident's temperature or assemble supplies. In addition, duties include observing, reporting, and documenting any changes in the resident or problems with the feeding. When a person is unable to swallow, he may be fed through a tube. A nasogastric tube is inserted into the nose and goes into the stomach. A tube can also be placed into the stomach through the abdominal wall. This is called a percutaneous endoscopic gastrostomy, PEG, tube. The surgically created opening into the stomach that allows the insertion of a tube is called a gastrostomy. Tube feedings are used when residents cannot swallow but can digest food. Conditions that may prevent swallowing include coma, cancer, stroke, refusal to eat, and extreme weakness. It is important to remember that residents have the legal right to refuse treatment. This includes the insertion of tubes. Figure 8-16, caption. Nasogastric tubes are inserted through the nose. PEG tubes are inserted through the abdominal wall into the stomach. NAs never insert or remove tubes, do the feeding, or irrigate, clean the tubes. They may assemble equipment and supplies and hand them to the nurse. NAs may position residents in a sitting position for feeding. They may also discard or clean and store used equipment and supplies. In addition, NAs may observe, report, and document any changes in the resident or problems with the feeding. Guidelines: tube feedings. Wash your hands before assisting with any aspect of tube feedings. Make sure the tube is not coiled, kinked, or resting underneath the resident. Be aware if resident has an order for nothing by mouth or NPO. The tube is only inserted and removed by a doctor or nurse. If it comes out, report it immediately. A doctor will prescribe the type and amount of feeding. The feeding should be at room temperature and in liquid form. A resident with a feeding tube should always have the head of the bed elevated 30 degrees. However, during a feeding, the resident should remain in a sitting position with the head of the bed elevated at least 45 degrees. This helps prevent serious problems such as aspiration. The elderly can develop pneumonia or even die from improper positioning during tube feedings. After the feeding, keep the resident upright for as long as ordered, at least 30 minutes. If the resident must remain in bed for long periods during feedings, give careful skin care. This helps to prevent pressure injuries on the hips and sacral area. Observing and reporting tube feedings. Report any of these to the nurse immediately. Redness or drainage around the opening. Skin sores or bruises. Cyanotic skin. Resident complaints of pain or nausea. Choking or coughing. Vomiting. Diarrhea. Swollen abdomen. Fever. Tube falls out. Problems with equipment. Sound of feeding pump alarm. Change of resident's inclined position. Learning Objective 9. Describe how to assist residents with special needs. Residents with specific diseases or conditions such as stroke, Parkinson's disease, Alzheimer's disease, or other dementias, head trauma, blindness, confusion, or those recovering from a stroke may need special assistance when eating. Guidelines. Dining techniques. Use assistive devices such as utensils with built-up handle grips and plate guards. Assistive devices for eating help people feed themselves. These devices should be included on the meal tray. Residents may benefit from physical and verbal cues. These promote independence. A cue is something that signals that a person should do something. The hand-over-hand approach is an example of a physical cue. The resident lifts a utensil if he is able. You put your hand over his to help with eating. With your hand placed over the resident's hand, help him get food on the utensil. Steer the utensil from the plate to the mouth and back. Repeat this until the resident is finished. Verbal cues must be short and clear. The cues should prompt the resident to do something. Give verbal cues one at a time. Wait until the resident has finished one task before asking him to do another. Repeat the cues until the resident is done eating. Examples of verbal cues include the following. Pick up your spoon. Put some carrots on your spoon. Raise the spoon to your lips. Open your mouth. Place the spoon in your mouth. Close your mouth. Take the spoon out of your mouth. Chew. Swallow. Drink some water. For residents who have a visual impairment, read menus to them if needed. When helping with eating, place the tray directly in front of the residents. Use the face of an imaginary clock to explain the position of what is in front of them. Figure 8-17, caption. Use the face of an imaginary clock to explain the position of food to residents who have a visual impairment. For residents who have had a stroke and have a paralyzed or weaker side, place food in the stronger side of the mouth. Make sure food is swallowed before offering another bite. Place food in the resident's field of vision. The nurse will determine a resident's field of vision. For residents who have Parkinson's disease, tremors or shaking can make it difficult to eat. Help by using physical cues. Place food and drinks close so that the resident can easily reach them. Use assistive devices as needed. If a resident has poor sitting balance, seat him in a regular dining room chair with armrests rather than in a wheelchair. Proper position in a chair means hips are at a 90-degree angle, knees are flexed, and feet and arms are fully supported. Push the chair under the table. Place forearms on the table. If a resident tends to lean to one side, ask him to keep his elbows on the table. If a resident has poor neck control, a neck brace may be used to stabilize the head. Use assistive devices as needed. If resident is in a jerry chair, a wedge cushion behind the head and shoulders may be used. If the resident bites down on utensils, ask him to open his mouth. Do not pull the utensil out of his mouth. Wait until his jaw relaxes. If the resident pockets food in his cheeks, ask him to chew and swallow the food. Touch the side of his cheek. Ask him to use his tongue to get the food. Using your fingers on the cheek, near the lower jaw, gently push the food toward his teeth. If the resident holds food in his mouth, ask him to chew and swallow the food. You may need to trigger swallowing. To do this, gently press down on the tongue when taking the spoon out of his mouth. You can also try to gently press down on the top of his head with your hand. Make sure the resident has swallowed the food before offering more. Residents' Rights Box 8-3, Residents with Special Needs. Residents have the right to be treated with dignity and as adults. They have the right to self-determination. This means, in part, that they should be given the opportunity to choose and state their preferences for care and services. For example, a resident who is blind may want to feed herself without using utensils. This may not look dignified to others, but it is the resident's choice. Chapter 9. Rehabilitation and Restorative Care. Learning Objective 1. Discuss rehabilitation and restorative care. When a resident loses some ability to function due to illness or injury, rehabilitation may be ordered. Rehabilitation is care that is managed by professionals. It helps to restore a person to his highest possible level of functioning. It involves helping residents move from illness, disability, independence, toward health, ability, and independence. Rehabilitation involves all parts of the person's disability. This includes physical, for example, eating, elimination, and psychosocial, for example, independence, self-esteem, needs. Goals of a rehabilitation program include the following: to help a resident regain function or recover from illness, to develop and promote a resident's independence, to help a resident to feel in control of his life, to help a resident accept or adapt to the limitations of a disability. Rehabilitation will be used for many residents, particularly those who have suffered a stroke, accident, joint replacement, or trauma. Restorative care usually follows rehabilitation. The goal of restorative care is to keep the resident at the level achieved by rehabilitative services. Restorative care works to maintain a resident's functioning, to improve his quality of life, and to increase independence. Both rehabilitation and restorative care take a person-centered team approach. Figure 9-1, caption. A team of specialists, including doctors, nurses, physical therapists, and other kinds of therapists, helps residents with rehabilitation. Because nursing assistants spend many hours with these residents, they are a very important part of the team. NAs play a critical role in helping residents recover and regain independence. Guidelines: restorative care. Be patient. Progress may be slow. The more patient you are, the easier it will be for them to regain abilities and confidence. Be positive and supportive. Focus on small tasks and small accomplishments. Break tasks down into small steps. Take everything one step at a time. Recognize that setbacks occur. Progress occurs at different rates. Reassure residents that setbacks are normal. Be sensitive to the residents' needs. Some residents may need more encouragement than others. Some may be embarrassed by encouragement. Understand what motivates your residents. Encourage independence. Independence improves self-image and attitude. It also helps speed recovery. Provide privacy. Ensuring privacy while residents try to do skills promotes dignity and maintains their legal rights. Involve residents in their care. Residents who feel involved and valued may be more motivated to work hard in rehabilitation. Observing and reporting. Restorative care. Any increase or decrease in abilities. Any change in attitude or motivation, positive or negative. Any change in general health, such as changes in skin condition, appetite, energy level, or general appearance. Signs of depression or mood changes. Residents' rights box 9-1, call lights. Residents may need help often while going through rehabilitation. No matter how often a resident uses his call light or how demanding he is, it is never acceptable for an NA to unplug a resident's call light. Call lights should always be left within reach of the resident's unaffected, stronger hand. Staff must respond kindly and promptly to call lights every time they are used. Learning Objective 2. Describe the importance of promoting independence and list ways exercise improves health. Maintaining independence is vital during and after rehabilitation and restorative services. When an active and independent person is dependent, physical and mental problems may result. The body becomes less mobile. The mind is less focused. Studies show that the more active a person is, the better the mind and body work. Inactivity and immobility can result in many problems, including the following: loss of self-esteem, depression, anxiety, boredom, pneumonia, urinary tract infection, skin breakdown and pressure injuries, constipation, blood clots, dulling of the senses, muscle atrophy, contractures, problems with independence and self-esteem. The staff's job is to keep residents as active as possible, whether they are bedbound or are able to walk, ambulate. Regular ambulation and exercise help improve these things: quality and health of the skin, circulation, strength, sleep and relaxation, mood, self-esteem, appetite, elimination, blood flow, oxygen level. Promoting social interaction and thinking abilities is important too. Most facilities have activities geared to residents' ages and abilities. Social involvement should be encouraged. When possible, NAs should join in activities with residents. This promotes independence. It also gives NAs a chance to observe residents' abilities. Learning Objective 3. Discuss ambulation and describe assistive devices and equipment. Ambulation is walking. A resident who is ambulatory is one who can get out of bed and walk. Many older residents are ambulatory but need help to walk safely. Several tools, including gait belts, canes, walkers, and crutches, help with ambulation. The NA should check the care plan before helping a resident ambulate. It is important to know the resident's abilities, limitations, and disabilities. The NA should communicate what she would like to do and allow the resident to do what he can. Procedure: assisting a resident to ambulate. Equipment needed: gait belt, non-skid shoes for resident. 1. Identify yourself by name. Identify the resident by name. Resident has right to know identity of his or her caregiver. Addressing resident by name shows respect and establishes correct identification. 2. Wash your hands. Provides for infection prevention. 3. Explain procedure to resident. Speak clearly, slowly, and directly. Maintain face-to-face contact whenever possible. Promotes understanding and independence. 4. Provide for resident's privacy with curtain, screen, or door. Maintains resident's right to privacy and dignity. 5. Adjust the bed to its lowest position. Lock bed wheels. Assist the resident into a sitting position. Make sure his feet are flat on the floor. Adjust the bed height if needed. Prevents injury and promotes stability. 6. Before ambulating, put non-skid footwear on the resident and fasten securely. Promotes resident safety. Prevents falls. 7. Stand in front of and face the resident. Place your feet about shoulder width apart. Promotes proper body mechanics. 8. Place the gait belt around the resident's waist over his clothing, not on bare skin. Grasp the belt securely on both sides, with hands in an upward position. 9. If the resident is unable to stand without help, brace, support, the resident's lower extremities. This can be done by placing one or both of your knees against the resident's knees. Bend your knees. Keep your back straight. Figure 9-2, caption. If the resident has a weak knee, brace it against your knee. 10. Hold the resident close to your center of gravity. Provide instructions to allow the resident to help with standing. Tell the resident to lean forward, push down on the bed with his hands, and stand on the count of 3. When you start to count, begin to rock. On 3, with hands still grasping the gait belt on both sides and moving upward, rock your weight onto your back foot. Slowly help the resident to stand. 11. Walk slightly behind and to one side of the resident for the full distance, while holding onto the gait belt. If the resident has a weaker side, stand on the weaker side. Use the hand that is not holding the belt to offer support on the weak side. Ask the resident to look forward, not down at the floor, during ambulation. Promotes resident safety, prevents injury. Figure 9-3, caption. Standing on the weaker side, walk behind the resident while holding onto the gait belt. 12. After ambulation, remove the gait belt. Help the resident to the bed or chair. Check that the resident is in proper alignment. 13. Leave bed in its lowest position. Provides for safety. 14. Place call light within resident's reach. Allows resident to communicate with staff as necessary. 15. Wash your hands. Provides for infection prevention. 16. Report any changes in resident to the nurse. Provides nurse with information to assess resident. 17. Document procedure using facility guidelines. If you do not document the care, legally it did not happen. When helping a resident who has a visual impairment walk, the NA should be beside and slightly ahead of the resident. The resident should be able to place his hand on the NA's elbow. The NA should walk at a normal pace. She should let the resident know when they are about to turn a corner or when a step is approaching. The NA should state whether they will be stepping up or down. Residents who have trouble walking may use canes, walkers, or crutches to help themselves. Canes help with balance. Residents using canes should be able to bear weight on both legs. If one leg is weaker, the cane should be held in the hand on the stronger side. Types of canes are the C cane, the functional grip cane, and the quad cane. The C cane is a straight cane with a curved handle at the top. It has a rubber-tipped bottom to prevent slipping. A C cane is used to improve balance. A functional grip cane is similar to the C cane, except that it has a straight grip handle rather than a curved handle. The grip handle helps improve grip control. It provides more support than the C cane. A quad cane has 4 rubber-tipped feet and a rectangular base. It is designed to bear more weight than the other canes. Figure 9-4, caption. A quad cane has 4 rubber-tipped feet and can bear more weight than other canes. A walker is used when the resident can bear some weight on both legs. The walker gives stability for residents who are unsteady or lack balance. The metal frame may have rubber-tipped feet and/or wheels. Crutches are used for residents who can bear no weight or limited weight on one leg. Crutches have rubber-tipped feet to prevent sliding. Some people use 1 crutch. Some use 2. Figure 9-5, caption. The photo on the left shows a standard walker, and the photo on the right shows a hemi-walker, which is a walker that is designed for people who have difficulty using an arm or a hand. Copyright Invacare Corporation, used with permission, www.invacare.com. Guidelines, cane or walker use. Be sure the walker or cane is in good condition. It must have rubber tips on the bottom. The tip should not be cracked. Walkers may have wheels. If so, roll the walker to make sure the wheels are moving properly. Be sure the resident is wearing securely fastened, non-skid shoes before ambulating. When using a cane, the resident should place it on his stronger side. When using a walker, have the resident place both hands on the walker. The walker should not be overextended. It should be placed no more than 6 inches in front of the resident. Stay near the resident on the weaker side. Do not hang purses or clothing on the walker. If height of the cane or walker does not appear to be correct, too short, too tall, etc., tell the nurse. Procedure: assisting with ambulation for a resident using a cane, walker, or crutches. Equipment needed: gait belt, non-skid shoes for the resident, cane, walker, or crutches. 1. Identify yourself by name. Identify the resident by name. Resident has right to know identity of his or her caregiver. Addressing resident by name shows respect and establishes correct identification. 2. Wash your hands. Provides for infection prevention. 3. Explain procedure to resident. Speak clearly, slowly, and directly. Maintain face-to-face contact whenever possible. Promotes understanding and independence. 4. Provide for residents' privacy with curtain, screen, or door. Maintains residents' right to privacy and dignity. 5. Adjust the bed to its lowest position so that the feet are flat on the floor. Lock bed wheels. Prevents injury and promotes stability. 6. Before ambulating, put non-skid footwear on the resident and securely fasten. Promotes resident safety. Prevents falls. 7. Stand in front of and face the resident. Place your feet about shoulder width apart. Promotes proper body mechanics. 8. Place the gait belt around the resident's waist over his clothing, not on bare skin. Grasp the belt securely on both sides, with hands in an upward position. 9. If the resident is unable to stand without help, brace, support, resident's lower extremities. See previous procedure. Bend your knees. Keep your back straight. Help the resident to stand as described in the previous procedure. 10. Help as needed with ambulation. A. Cane. Resident places cane about 6 inches or a comfortable distance in front of his stronger leg. He brings his weaker leg even with the cane. He then brings his stronger leg forward slightly ahead of the cane. Repeat. B. Walker. Resident picks up or rolls the walker. He places it about 6 inches or a comfortable distance in front of him. All 4 feet or wheels of the walker should be on the ground before the resident steps forward to the walker. The walker should not be moved again until the resident has moved both feet forward and is steady. The resident should never put his feet ahead of the walker. Promotes stability and prevents falls. C. Crutches. Residents should be fitted for crutches and taught to use them correctly by a physical therapist or a nurse. The resident may use the crutches several different ways. It depends on his weakness. No matter how they are used, the resident's weight should be on his hands and arms. Weight should not be on the underarm area. 11. Walk slightly behind and to one side of the resident for the full distance, while holding onto the gait belt. If the resident has a weaker side, stand on the weaker side. Provide security. 12. Watch for obstacles in the resident's path. Ask the resident to look forward, not down at the floor during ambulation. Promotes resident safety. Prevents injury. 13. Encourage resident to rest if he is tired. When a person is tired, it increases the chance of a fall. Let the resident set the pace. Discuss how far he plans to go based on the care plan. 14. After ambulation, remove the gait belt. Help the resident to the bed or chair. Check that the resident is in proper alignment. 15. Leave bed in its lowest position. Provides for safety. 16. Place call light within resident's reach. Allows resident to communicate with staff as necessary. 17. Wash your hands. Provides for infection prevention. 18. Report any changes in resident to the nurse. Provides nurse with information to assess resident. 19. Document procedure using facility guidelines. If you do not document the care, legally it did not happen. Many devices are available to help people who are recovering from or adapting to a physical condition. Assistive or adaptive devices help residents perform their activities of daily living, ADLs. Each device is made to support a particular disability. Raised seating, for example, makes it easier for a resident with weak legs to stand. Personal care equipment includes long-handled brushes and combs. Plate guards prevent food from being pushed off the plate. They make it easier to scoop food onto utensils. Reachers can help put on underwear or pants. A sock aid can pull on socks. A long-handled shoehorn assists in putting shoes on without bending. Long-handled sponges help with bathing. Supportive devices, such as canes, walkers, and crutches, are used to assist residents with ambulation. Safety devices, such as shower chairs and gate or transfer belts, help prevent accidents. Safety bars, grab bars, are often installed in and near the tub and toilet to give the resident something to hold onto while changing position. More examples of assistive devices are shown in Figure 9-6. Figure 9-6, caption. Many assistive items are available to help residents adapt to physical changes. Photos courtesy of North Coast Medical Incorporated, www.ncmedical.com, 800-821-9319. Learning Objective 4. Explain guidelines for maintaining proper body alignment. Residents who are confined to bed need proper body alignment. This aids recovery and prevents injury to muscles and joints. By following these guidelines, NAs can help residents maintain proper alignment. Guidelines: alignment and positioning. Observe principles of alignment. Proper alignment is based on straight lines. The spine should lie in a straight line. Pillows or rolled or folded blankets can support the small of the back and raise the knees or head in the supine position. They can support the head and one leg in the lateral position. Figure 9-7, caption. Pillows or rolled or folded blankets help provide extra support. Keep body parts in natural positions. In a natural hand position, the fingers are slightly curled. Use a rolled washcloth, gauze bandage, or a rubber ball inside the palm to support the fingers in this position. Use bed cradles to keep covers from resting on feet in the supine position. Prevent external rotation of hips. When legs and hips turn outward during bed rest, hip contractures can result. A rolled blanket or towel tucked alongside the hip and thigh can keep the leg from turning outward. Change positions often to prevent muscle stiffness and pressure injuries. This should be done at least every 2 hours. The position used will depend on the resident's condition and preference. Check the resident's skin every time you reposition him. Give back rubs as ordered for comfort and relaxation. Learning Objective 5. Describe care guidelines for prosthetic devices. Amputation is the surgical removal of some or all of a body part, usually an arm, hand, leg, or foot. Amputation may be the result of an injury or disease. After amputation, some people feel that the limb is still there. They may feel pain in the part that has been amputated. Phantom sensation is the term used when a person feels that the body part is still there. Phantom limb pain occurs when the person feels pain in a limb or extremity that has been amputated. It may last for a short time or for years. The pain or sensation is real. It should not be ignored. Medication or physical therapy may be used to treat these conditions. A prosthesis is a device that replaces a body part that is missing or deformed because of an accident, injury, illness, or birth defect. It is used to improve a person's ability to function and/or to improve appearance. Examples of prostheses include the following. Artificial limbs, such as artificial hands, arms, feet, and legs, are made to resemble the body part that they are replacing. An artificial breast is made of a lightweight, soft, spongy material. A hearing aid is a small device that amplifies sound for persons with hearing loss. An artificial eye or ocular prosthetic replaces an eye that has been lost to disease or injury. An ocular prosthetic does not provide vision. It can, however, improve appearance. Dentures are artificial teeth. They may be necessary when a tooth or teeth have been damaged, lost, or must be removed. Guidelines: amputation and prosthesis care. Residents who have had a body part amputated must make many physical, psychological, social, and occupational adjustments due to disability. Be supportive. Help residents with their ADLs. Prostheses are specially fitted, expensive pieces of equipment. Some cost tens of thousands of dollars. Care for them as assigned. Handle them carefully. A therapist or nurse will demonstrate application of a prosthesis. Follow instructions to apply and remove the prosthesis. Follow the manufacturer's care directions. Respect a resident's decision not to wear a prosthetic limb. Some residents may find the limb uncomfortable and only wish to wear it for special occasions. Keep a prosthesis and the skin under it dry and clean. The socket of the prosthesis must be cleaned at least daily. Follow the care plan and the nurse's instructions. If ordered, apply a stump sock before putting on the prosthesis. Observe the skin on the stump. Watch for skin breakdown caused by pressure and abrasion. Report any redness or open areas. Never try to fix a prosthesis. Report any problems to the nurse. Do not show negative feelings about the stump during care. Phantom limb pain is real pain. Treat it that way. Report complaints of pain to the nurse. If the resident has an artificial eye, review the care plan with the nurse. Always wash your hands and don gloves before handling an artificial eye. Provide privacy for the resident. Never clean or soak the eye in rubbing alcohol. It will crack the plastic and destroy it. If the eye is to be removed and not reinserted, store it in water or saline solution. Make sure the container is labeled with the resident's name and room number. The resident may be able to remove, clean, and insert the eye himself. Know any needed instructions for care. Information on care of hearing aids is in Chapter 2. Denture care is located in Chapter 6. Learning Objective 6. Describe how to assist with range of motion exercises. Range of motion, ROM, exercises put a joint through its full arc of motion. The goals of these exercises are to decrease or prevent contractures or atrophy, improve strength, and increase circulation. Active range of motion, AROM, exercises are done by a resident himself without help. The NA's role is to encourage the resident. Active assisted range of motion, AAROM, exercises are done by the resident with some help and support from the NA. Passive range of motion, PROM, exercises are used when residents are not able to move on their own. These exercises are done by a staff member without the resident's help. ROM exercises are specific for each body area. They include these movements. Abduction, moving a body part away from the midline of the body. Adduction, moving a body part toward the midline of the body. Extension, straightening a body part. Flexion, bending a body part. Dorsiflexion, bending backward. Rotation, turning a joint. Pronation, turning downward. Supination, turning upward. Opposition, touching the thumb to any other finger. Figure 9-8, caption, the different range of motion body movements. Range of motion exercises are not done without an order from a doctor, nurse, or physical therapist. The NA will repeat each exercise 3 to 5 times, once or twice a day, working on both sides of the body. When doing ROM exercises, the NA should begin at the resident's shoulders and work down the body. The upper extremities, arms, should be exercised before the lower extremities, legs. The NA should give support above and below the joint. The joint should be moved gently, slowly, and smoothly. It is important to ask if the exercises are causing pain. The NA should stop the exercises if the resident complains of pain and report the pain to the nurse. Procedure: assisting with passive range of motion exercises. 1. Identify yourself by name. Identify the resident by name. Resident has right to know identity of his or her caregiver. Addressing resident by name shows respect and establishes correct identification. 2. Wash your hands. Provides for infection prevention. 3. Explain procedure to resident. Speak clearly, slowly, and directly. Maintain face-to-face contact whenever possible. Promotes understanding and independence. 4. Provide for residents' privacy with curtain, screen, or door. Maintains residents' right to privacy and dignity. 5. Adjust bed to a safe level, usually waist high. Lock bed wheels. Prevents injury to you and to resident. 6. Position the resident lying supine, flat on her back, on the bed. Use proper alignment. Ask the resident to let you know if she has any pain during the procedure. Reduces stress to joints. Pain is a warning sign for injury. 7. While supporting the limbs, move all joints gently, slowly, and smoothly through the range of motion to the point of resistance. Repeat each exercise at least 3 times. Ask the resident if an exercise is causing pain. Watch for signs of pain. Stop if resident appears to be in pain or reports pain. Rapid movement may cause injury. Pain is a warning sign for injury. 8. Shoulder. Support the resident's arm at the elbow and wrist while performing ROM for the shoulder. Place one hand under the elbow and the other hand under the wrist. Raise the straightened arm from the side position upward toward the head to ear level. Return the arm down to the side of the body. Extension, flexion. Figure 9-9, caption. Raise the straightened arm upward toward head to ear level and return it to the side of the body. Keep one hand under the elbow and one hand under the wrist. Move the straightened arm away from the side of the body to shoulder level. Return the arm to the side of the body. Abduction, adduction. Figure 9-10, caption. Move the straightened arm away from the side of the body to shoulder level and return the arm to side. 9. Elbow. Hold the resident's wrist with one hand and the elbow with the other hand. Bend the elbow so that the hand touches the shoulder on that same side. Flexion. Straighten the arm. Extension. Figure 9-11. Caption. Bend the elbow so that the hand touches the shoulder on the same side. Then straighten the arm. Exercise the forearm by moving it so the palm is facing downward, pronation, and then the palm is facing upward, supination. Figure 9-12. Caption. Exercise the forearm so that the palm is facing downward and then upward. 10. Wrist. Hold the wrist with one hand. Use the fingers of the other hand to help move the joint through the motions. Bend the hand down, flexion. Bend the hand backward, dorsiflexion. Figure 9-13. Caption. While supporting the wrist, gently bend the hand down and then backward. Turn the hand in the direction of the thumb, radial flexion, then turn the hand in the direction of the little finger, ulnar flexion. Figure 9-14. Caption. Turn the hand in the direction of the thumb, then turn it in the direction of the little finger. 11. Thumb. Move the thumb away from the index finger, abduction. Move the thumb back next to the index finger, adduction. Figure 9-15. Caption. Move the thumb away from the index finger and then back to the index finger. Touch each fingertip with the thumb, opposition. Figure 9-16. Caption. Touch each fingertip with the thumb. Bend the thumb into the palm, flexion, and out to the side, extension. Figure 9-17. Caption. Bend the thumb into the palm and then out to the side. 12. Fingers. Make the hand into a fist, flexion. Gently straighten out the fist, extension. Figure 9-18. Caption. Make the fingers into a fist and then gently straighten out the fist. Spread the fingers and the thumb far apart from each other, abduction. Bring the fingers back next to each other, adduction. Figure 9-19. Caption. Spread the fingers and thumb far apart from each other and then bring them back next to each other. 13. Hip. Support the leg by placing one hand under the knee and one under the ankle. Straighten the leg and gently raise it upward. Move the leg away from the other leg, abduction. Move the leg toward the other leg, adduction. Figure 9-20. Caption. Straighten the leg and gently raise it. Move the leg away from the other leg and then back toward the other leg. Gently turn the leg inward, internal rotation, and then turn the leg outward, external rotation. Figure 9-21. Caption. Gently turn the leg inward and then outward. 14. Knee. Support the leg under the knee and under the ankle while performing ROM for the knee. Bend the knee to the point of resistance, flexion. Return the leg to resident's normal position, extension. Figure 9-22. Caption. Gently bend the knee to the point of resistance and return the leg to its normal position. 15. Ankle. Support the foot and under the ankle close to the bed while performing ROM for the ankle. Push, pull foot up toward the head, dorsiflexion. Push, pull foot down, with the toes pointed down, plantar flexion. Figure 9-23. Caption. Push the foot up toward the head and then push it back down. Turn the inside of the foot inward toward the body, supination. Bend the sole of the foot so that it faces away from the body, pronation. Figure 9-24. Caption. Turn the inside of the foot inward toward the body, and then bend it to face away from the body. 16. Toes. Curl and straighten the toes, flexion and extension. Figure 9-25. Caption. Curl and straighten the toes. Gently spread the toes apart, abduction. Figure 9-26. Caption. Gently spread the toes apart. 17. Return resident to a comfortable position. Return bed to lowest position. Promotes resident safety. 18. Place call light within resident's reach. Allows resident to communicate with staff as necessary. 19. Wash your hands. Provides for infection prevention. 20. Report any changes in resident to nurse. Provides nurse with information to assess resident. 21. Document procedure using facility guidelines. Note any decrease in range of motion or any pain experienced by the resident. Notify the nurse or the physical therapist if you find increased stiffness or physical resistance. Resistance may be a sign that a contracture is developing. If you do not document the care, legally it did not happen. Learning Objective 7. List guidelines for assisting with bladder and bowel retraining. Injury, illness, or inactivity may cause a loss of normal bladder or bowel function. Residents may need help to re-establish a regular routine and normal function. Problems with elimination can be embarrassing or difficult to discuss. NA should be sensitive to this. They should be professional when handling incontinence or working to re-establish routines. Guidelines: bladder or bowel retraining. Follow standard precautions. Wear gloves when handling body wastes. Explain the training schedule to the resident. Follow the schedule carefully. Keep a record of the resident's bladder and bowel habits. When you see a pattern of elimination, you can predict when the resident will need a bedpan or a trip to the bathroom. Offer a bedpan or a trip to the bathroom before beginning long procedures. Encourage the resident to drink plenty of fluids. Do this even if urinary incontinence is a problem. About 30 minutes after fluids are taken, offer a trip to the bathroom or a bedpan or urinal. Encourage the resident to eat foods that are high in fiber. Encourage residents to follow special diets as ordered. Answer call lights promptly. Residents cannot wait long when the urge to go to the bathroom occurs. Leave call lights within reach. Provide privacy for elimination, both in the bed and in the bathroom. If a resident has trouble urinating, try running water in the sink. Have her lean forward slightly. This puts pressure on the bladder. Do not rush the resident. Help the resident with careful perineal care. This helps prevent skin breakdown and promotes proper hygiene. Observe for skin changes. Discard wastes according to facility policy. Discard clothing protectors and incontinence briefs properly. Double bag these items if ordered. This stops odors from collecting. Figure 9-27, caption: a type of incontinence pad. Some facilities use washable bed pads or briefs. Follow standard precautions when handling these items. Keep an accurate record of urination and bowel movements. This includes episodes of incontinence. Praise successes or even attempts to control the bladder and bowels. However, do not talk to residents as if they are children. Keep your voice low. Do not draw attention to any aspect of retraining. Do not discuss accident or retraining in public areas. Never show frustration or anger toward residents who are incontinent. The problem is out of their control. Negative reactions will only make things worse. Be kind, supportive, and professional. When the resident is incontinent or cannot use the toilet when asked, be positive. Never make the resident feel like a failure. Praise and encouragement are essential for a successful program. Each resident has different needs and may respond to different types of encouragement. Finding out each resident's needs and preferences is part of giving person-centered care. Some residents will always be incontinent. Be patient. Offer these residents extra care and attention. Skin breakdown may lead to pressure injuries without proper care. Always report changes in skin. Orange Box 9-1, changing incontinence briefs. When changing an incontinence brief, the NA should assemble all needed items beforehand, including a protective pad, perineal care supplies, disposable wipes, gloves, and a clean brief. She should don gloves before handling the brief. When removing the soiled brief, the NA should roll it inward, soiled side inside, without spilling its contents. Working from front to back, she should carefully remove all urine and/or feces from the skin. After cleaning the area thoroughly, she should blot it dry and put on the clean brief. Chapter 10, Caring for Yourself. The first 9 chapters of this book introduce readers to the long-term care setting. They cover the knowledge, skills, and qualities a person needs to work as a nursing assistant. This final chapter is more personal. It addresses the reader directly. This chapter has to do with finding and keeping a job, as well as advice about building good working relationships. It also includes helpful tips for managing stress and staying healthy. Learning Objective 1. Describe how to find a job. Once your training is complete, you may soon be looking for a job. Nursing assistants may be able to work in long-term care facilities, in assisted living facilities, in hospitals, in the home, and in other places. To find a job, you must first find potential employers. Then you must contact them to find out about job opportunities. To find employers, use the internet, a newspaper, or personal contacts. You can also ask your instructor about potential employers. Figure 10-1, caption: using the internet is a good way to find a job. Once you have a list of potential employers, you need to contact them. Emailing or phoning first, unless they mention not to do so, is a good way to find out what jobs are available. Ask how to apply for a job with each potential employer. When making an appointment, ask what information to bring with you. Make sure you have this information with you when you go. Some of these documents may be required. Identification, including driver's license, social security card, birth certificate, passport, or other official form of identification. Proof of your legal status in this country and proof that you are legally able to work even if you are a U.S. citizen. All employers must have files showing that all employees are legally allowed to work in this country. Do not be offended by this request. High school diploma or equivalency. school transcripts, and diploma or certificate from your nursing assistant training course. Take your instructor's name, phone number, and email address with you as well. References are people who can be contacted to recommend you as an employee. They include former employers and/or former teachers. Do not use relatives or friends as references. You can ask references beforehand to write general letters for you. They can be addressed to whom it may concern and should explain how they know you and describe your skills, qualities, and work habits. Take copies of these with you. Some potential employers will ask you for a resume. A resume is a summary or listing of relevant job experience and education. When creating your resume, keep it brief, 1 page is best, and clear. Include this information: your contact details, name, address, phone number, and email address. Your educational experience, starting with the most current first. Your work experience, starting with the most current first. Any special skills, such as knowledge of computer software, typing skills, or speaking other languages. Any memberships in professional organizations. Volunteer work. A job application may need to be completed. Write down the general information you will need. Take this information with you, along with your resume if you have one. This will save you time and avoid mistakes. Include this information: your address, phone number, and email address, your birth date, your social security number, name and address of the school or program where you trained, and the date you completed your training, as well as your certification number and information about other certifications, such as CPR and first aid. Names, titles, addresses, phone numbers, and email addresses of former employers, and the dates you worked there. Salary information from your former jobs. Reasons why you left each of your former jobs. Names, addresses, phone numbers, and email addresses of your references. Days and hours you can work. A brief statement about why you are changing jobs or why you want to work as a nursing assistant. Fill out the application carefully and neatly. Never lie. Before you write anything, read it all the way through once. If you are not sure what is being asked, find out before filling in that space. Fill in all of the blanks. Write N/A, not applicable, if the question does not apply to you. Your employer may require that a criminal background check be done on new employees. You may be asked to sign a form granting permission to do this. Do not take it personally. It is a law intended to protect patients and residents. To make the best impression at a job interview, be professional. Do the following: shower or bathe. Use deodorant. Brush your teeth. Wash your hands and clean and file your nails. Nails should be medium length or shorter. Do not wear artificial nails. Wear only simple makeup and jewelry, or none at all. Your hair should be clean and out of your eyes. Wear it in a simple style. Shave or trim facial hair before the interview. Dress neatly and appropriately. Make sure clothing is clean, ironed, and has no holes in it. Do not wear jeans, shorts, or short dresses or skirts, no shorter than knee length. Do not wear t-shirts or anything with a logo or writing on it. Shoes should be clean and polished. Do not wear sneakers or flip-flops. Do not wear perfume or cologne. Many people dislike or are allergic to scents. Do not smoke beforehand. You will smell like smoke during the interview. Arrive 10 or 15 minutes early. Do not bring friends or children with you. Turn off your phone. Introduce yourself. Smile and shake hands. Your handshake should be firm and confident. Figure 10-2, caption. Smile and shake hands confidently when you arrive at a job interview. Answer questions clearly and completely. Make eye contact to show you are sincere. Avoid slang words or expressions. Do not eat, drink, chew gum, or smoke in an interview. Sit up or stand up straight. Look happy to be there. Relax and be confident. You have worked hard to get this far. Be positive when answering questions. Emphasize what you enjoy or think you will enjoy about the job. Do not complain about any previous jobs you have had. Make it clear that you are hardworking and willing to work with all kinds of residents. Usually, interviewers will ask if you have any questions. Have some prepared. Write them down so you do not forget things you really want to know. Questions you may want to ask include: what hours would I work? Is there any mandatory overtime I would need to work? What benefits does the job include? Is health insurance available? Would I get paid sick days or holidays? What is the average caseload for nursing assistants? What orientation or training is provided? How will I contact my supervisor when I need to do so? Are there any policies regarding ongoing education or advancement? How soon will you be making a decision about this position? Later in the interview, you may want to ask about salary or wages if you have not already been given this information. Listen carefully to the answers to your questions. Take notes if needed. You will probably be told when you can expect to hear from the employer about the job. Do not expect to be offered a job at the interview. When the interview is over, stand up and shake hands again. Thank the employer for meeting with you. Send an email or letter after the interview to say thank you. Express your continued interest in the job. If you have not heard back from the employer within the time frame you discussed with your interviewer, call and politely ask if the job has been filled. Learning Objective 2. Describe a standard job description and explain how to manage time and assignments. A job description is an agreement between the employer and the employee. When you start a new job, you will receive a job description. It states the responsibilities and tasks of the job. It also describes the skills required for the job, to whom you must report, and the salary range. The job description provides protection for you and your employer. It protects you, the employee, from the facility changing duties without notifying you. It protects you from being fired based on something not related to your job description. The employer is protected if you ever were to claim you did not know certain duties were part of the job. The job description reduces misunderstandings. It can be used to document what was agreed upon if legal issues occur. When taking care of residents, you must be able to manage your time well. There are many tasks that must be done during your shift. Managing time properly helps you complete these tasks. Many of the following ideas for managing time on the job can be used to manage personal time as well. Plan ahead. Planning is the single best way to manage time better. Sometimes it is hard even to find time to plan, but it is important to sit down and list everything that has to be done. It is helpful to take time to check to see if you have all the supplies needed for a procedure before you begin. Often just making the list and taking time to recheck will help you focus and feel better. The nurse creates nursing assistants work assignments based on the needs of residents and availability of staff. The assignments allow staff to work as a team. Your responsibilities in completing assignments include the following: helping others when needed, never ignoring a resident who needs help, answering all call lights even when not assigned to a particular resident, notifying the nurse if you cannot complete an assignment. Prioritize. Identify the most important things to get done and do them first. Make a schedule. Write out the hours of the day and fill in what needs to be done and when. This allows for a realistic schedule. Combine activities. You can visit with residents while providing care, which combines two important tasks. Work more efficiently whenever possible. Get help. It is a simple reality that it is not possible for you to do everything. Sometimes you will need help to ensure a resident's safety. Do not be afraid to ask for help. Learning Objective 3. Discuss how to manage and resolve conflict. Everyone experiences conflict at some point in his life. For example, families may argue at home, coworkers may disagree on the job, and so on. If conflict at work is not managed or resolved, it may affect the ability to function well. The work environment may suffer. When conflict occurs, there is a proper time and place to address it. You may need to talk to your supervisor for help. In general, follow these guidelines. Guidelines: resolving conflict. Plan to discuss the issue at the right time. Do not start a conversation while you are helping residents. Wait until the supervisor has decided on the right time and place. Privacy is important. Shut the door. Limit distractions, such as TV and conversations. Agree not to interrupt the person. Do not be rude or sarcastic or name call. Use active listening. Take turns speaking. Do not get emotional. Some situations may be upsetting. However, you will be more effective in communicating if you can keep your emotions out of it. Check your body language. Make sure it is not tense, unwelcoming, or threatening. Maintain eye contact. Use a posture that says you are listening and interested. Lean forward slightly. Do not slouch. Keep the focus on the issue at hand. When discussing conflict, state how you feel when a behavior occurs. Use I statements. First describe the actual behavior. Then use feeling words to describe how you feel. Let the person know how the problem is affecting you. For example, when you are late to work, I feel upset because I end up doing your work along with my own. People involved in the conflict may need to come up with possible solutions. Think of ways that the conflict can be resolved. A solution may be chosen by a supervisor that does not satisfy everyone. You may have to compromise. Be prepared to do this. Learning Objective 4. Describe employee evaluations and discuss appropriate responses to feedback. From time to time, you will get evaluations from your employer. They contain ideas to help you improve your job performance, which is often referred to as constructive feedback. Constructive feedback involves giving opinions about a person's work and making helpful suggestions for change. The feedback may be positive or negative, but it is given in a non-aggressive way. Here are some ideas for handling feedback and using it to your benefit. Listen to the message that is being sent. Try not to get upset so you can understand the message. Hostile criticism is not the same as constructive feedback. Hostile criticism is angry and negative. Examples are, "You are useless," or "You are lazy and slow." Hostile criticism should not come from your employer or supervisor. You may hear hostile criticism from residents, family members, or others. The best response is something like, "I'm sorry you are so disappointed," and nothing more. Give the person a chance to calm down before trying to discuss their comments. Constructive feedback may come from your employer, supervisor, or others. Constructive feedback is meant to help you improve. Examples are, "You really need to be more accurate in your charting," or "You are late too often. You'll have to make more of an effort to be on time." Listening to, accepting, and acting on constructive criticism can help you be more successful in your job. Pay attention to it. If you are not sure how to avoid a mistake you have made, always ask for suggestions on improving your performance. Figure 10-3, Caption. Ask for suggestions when receiving constructive feedback. Apologize and move on. If you have made a mistake, apologize as needed. This may be to a supervisor, a resident, or others. Learn from the incident and put it behind you. Do not dwell on it or hold a grudge. Responding professionally to feedback is important for success in any job. Figure 10-4, Caption. Be willing to apologize if you have made a mistake. Your evaluation will also cover overall knowledge, conflict resolution, and team effort. Flexibility, friendliness, trustworthiness, and customer service will also be considered. Evaluations are often the basis for salary increases. A good evaluation can help you advance within the company. Being open to feedback and suggestions for improvement will help you be more successful. If you decide to change jobs, be responsible. Always give your employer at least 2 weeks written notice that you will be leaving. Otherwise, your facility may be understaffed. Both the residents and other staff will suffer. Future employers may talk with past supervisors. People who change jobs too often or who do not give notice before leaving are less likely to be hired. Learning Objective 5. Discuss certification and explain the state's registry. To meet requirements set forth in the Omnibus Budget Reconciliation Act, OBRA, states must regulate nursing assistant training, evaluation, and certification. OBRA requires 75 hours as the minimum level of initial training and a 12-hour minimum for annual continuing education, called in-services. Many states' requirements exceed the minimum hours. It is a good idea to know your state's rules. After completing an approved training program, NAs are given a competency evaluation, a certification exam or test, so that they can be certified to work in a state. This exam usually has both a written and skills evaluation. You must pass both parts in order to be certified to work as a nursing assistant. OBRA also requires that each state keep a registry of nursing assistants. This registry is maintained by a state department. Often this is the state's Board of Nursing or Department of Health. The registry contains NA's training information and results of certification exams. It also has any findings of abuse, neglect, or theft by nursing assistants. Employers are able to access this list to check if you have passed the certification exam. They can see if your certification is current. They are also able to see if you have been investigated for or are found guilty of abuse or neglect. Each state has different requirements for maintaining certification. Learn your state's requirements. Follow them exactly or you will not be able to keep working. Once you are certified, you can lose your certification if you fail to follow your state's rules. This can occur if you do not work in long-term care for a period of time or fail to get the required number of continuing education hours. You can also lose certification due to criminal activities, including abuse and neglect. Learning Objective 6. Describe continuing education. The federal government requires that nursing assistants have a 12-hour minimum of continuing education each year. Many states may require more. In-service continuing education courses help you keep your knowledge and skills fresh. Classes also give more information about certain conditions, challenges in working with residents, or regulation changes. You need to be up to date on the latest that is expected of you. Your employer may be responsible for offering in-service courses. However, you are responsible for attending and completing them. You must do the following. Sign up for the course or find out where it is offered. Attend all class sessions. Pay attention and complete all the class requirements. Make the most of your in-service programs. Participate. Figure 10-5, Caption. Students should pay attention and participate during continuing education courses. Keep original copies of all certificates and records of your successful attendance so you can prove you took the class. Learning Objective 7. Explain ways to manage stress. Stress is the state of being frightened, excited, confused, in danger, or irritated. It is often thought that only bad things cause stress. However, positive situations cause stress too. For example, getting married, or having a baby are usually positive situations, but both can cause enormous stress from the changes they bring to a person's life. You may be thrilled when you get your new job, but starting work may also cause you stress. You may be afraid of making mistakes, excited about earning money or helping people, or confused about your new duties. Learning how to recognize stress and what causes it is helpful. Then you can master a few simple methods for relaxing and learn to manage stress. A stressor is something that causes stress. Anything can be a stressor. Some examples include the following: divorce, marriage, new baby, parenthood, children growing up, children leaving home, feeling unprepared for a task, starting a new job, problems at work, new responsibilities at work, feeling unsupported at work, not enough guidance and resources, losing a job, supervisors, co-workers, residents, illness, finances. Stress is not only an emotional response, it is also a physical response. When a person has stress, changes occur in the body. The endocrine system makes more of the hormone adrenaline. This can increase nervous system response, heart rate, respiratory rate, and blood pressure. This is why in stressful situations, your heart beats fast, you breathe hard, and you may feel warm or perspire. Each person has a different tolerance level for stress. What one person would find overwhelming might not bother another person. A person's tolerance for stress depends on his personality, life experiences, and physical health. Guidelines: managing stress. To manage stress in your life, develop healthy dietary, exercise, and lifestyle habits. Eat nutritious foods. Exercise regularly. You can exercise alone or with others. Figure 10-6, caption: regular exercise is one healthy way to decrease stress. Get enough sleep. Drink only in moderation. Do not smoke. Find time at least a few times a week to do something relaxing, such as reading a book, sewing, watching a movie, or any of the following: being in nature, doing something artistic, painting, drawing, writing, singing, etc., doing yoga, getting a massage, listening to music, meditating. Not managing stress can cause many problems. Some of these problems affect how well you do your job. Signs that you are not managing stress well include the following: showing anger or being abusive to residents, arguing with your supervisor about assignments, having poor relationships with coworkers and residents, complaining about your job and your responsibilities, feeling work-related burnout. Burnout is a state of mental or physical exhaustion caused by stress. Feeling tired even when you are rested. Having trouble focusing on residents and procedures. Stress can seem overwhelming when you try to handle it yourself. Often just talking about stress can help you manage it better. Sometimes another person can offer helpful suggestions. You may think of new ways to handle stress just by talking it through with another person. Get help from one or more of these resources when managing stress: your supervisor or another member of the care team for work-related stress, your family, your friends, a support group, your place of worship, your doctor, a local mental health agency, any phone hotline that deals with related problems. Check online. It is not appropriate to talk to your resident or their family members about your personal or job-related stress. Developing a plan to manage stress can be helpful. The plan can include nice things you will do for yourself every day and things to do in stressful situations. Before making a plan, first answer these questions. What are the sources of stress in my life? When do I most often feel stress? What effects of stress do I see in my life? What can I change to decrease the stress I feel? What do I have to learn to cope with because I cannot change it? When you have answered these questions, you will have a clearer picture of the challenges you face. Then you can come up with strategies for managing stress. Orange Box 10-1, the body scan. A relaxation exercise can often help you feel refreshed and relaxed in only a short time. Below is a simple relaxation exercise. Try it out. See if it helps you feel more relaxed. Close your eyes. Focus on your breathing and posture. Be sure you are comfortable. Starting at the balls of your feet, concentrate on your feet. Find any tension hidden in the feet. Try to relax and release the tension. Continue very slowly. Take a breath between each body part. Move up from the feet, focusing on and relaxing the legs, knees, thighs, hips, stomach, back, shoulders, neck, jaw, eyes, forehead, and scalp. Take a few very deep breaths. Open your eyes. Look back over all you have learned in this program. Your work as a nursing assistant is very important. Every day may be different and challenging. In 100 ways every week, you will offer help that only a caring person like you can give. Do not forget to value the work you have chosen to do. Your work can mean the difference between living with independence and dignity and living without. The difference you make is sometimes life versus death. Look in the face of each of your residents. Know that you are doing important work. Look in a mirror when you get home. Be proud of how you make your living. Figure 10-7, caption. Value your work. Be proud of what you have chosen to do. This has been Hartman's Nursing Assistant Care, The Basics, 5th edition. Written by Hartman Publishing Incorporated, with Jetta Fuzzi, RN, MS. Narrated by Victoria Phelps, BSN, RN, BC. Produced by Mark